Welcome to the GIE Author Interview Series. I'm Dr. Glenn Eisen, the Editor-in-Chief of Gastrointestinal Endoscopy. With me today is Dr. William Brugge, who is a professor of medicine at Harvard Medical School and the director of endoscopy at the Massachusetts General Hospital. He is the senior author on this paper, and he'll be discussing leaks and endoscopic assessment of break of integrity after Notes gastrotomy. Nice to see you, Dr. Brugge. That's a mouthful.
It is quite a mouthful.
Can you explain a little bit about the intent and purpose of your study?
Well, as you know, the name of the study, I think, was very appropriate. It was called the leaking study.
Right.
And the purpose of the study is to try to answer a very important question in Notes. As you know, Notes is involved in the transgastric procedures where we go into the peritoneal cavity to operate, retrieve, or to examine the peritoneal cavity. And the critical aspect of the procedure is not getting out, but it's getting through and exiting from the stomach very safely and then closing the gastrotomy. So we asked a very important question, and that is, can we do a test, can we do an endoscopic test to determine whether the closure is adequate or not? And we wanted a fairly simple endoscopic test where that could easily be done in humans. So we examined this in an animal study.
Okay. Two questions to start. First, how much of a problem are leaks in Notes procedures?
So I think leaks are a very important problem and very common, and that's because we don't have the right technique and the right tools. And we all know this, and we're all working feverishly with industry to come up with better closures. But right now we do not have the ideal closure mechanism.
And my second question is, what's the current standard technique for evaluating whether a leak is present and acting in a proactive manner before you develop complications?
Well, that's a very good question. As you know, the time-honored approach to these kinds of procedures is to determine if a leak is present using radiographs, meaning we put contrast into the stomach, we do an X-ray and try to determine if there's extravasation of contrast out of the stomach. This is, as you might imagine, a fairly crude procedure, and it's a very crude technique for looking at fairly gross leaks out of the stomach. And so we wanted something that would not involve the use of radiology, and that's something that could be done endoscopically while we are present during the procedure.
Right. Something more in real time rather than
Correct.
finishing the procedures, sending them for an X-ray, realizing you have a hole and going back.
Exactly.
Okay, so describe the techniques you employed.
So we thought that maybe we could look at the pressure in the stomach that's generated by the infusion of air. As we all know, these endoscopes have air pumps, and the air is pumped into the gastric cavity. And we did a fairly simple procedure where we used the air pressure that's generated in the stomach with the processor. And then we had a little pressure transducer going through the scope. And we just simply measured the pressure in the stomach as we were infusing air over a period of time. And we chose 120 minutes, and we chose a maximum pressure cutoff value of 15 millimeters of mercury to try to differentiate between those animals that had leaks and those that did not. And our hypothesis is that if you have a hole in your stomach, the pressure generated is going to be lower than as if you have an intact stomach.
Makes sense to me. So tell me a little bit about the results of the study.
Well, what we're trying to do is randomize the animals so that we could do this kind of prospectively in a very scientific fashion. So we took a group of animals after we had established the test and we knew that it worked. Then we applied this to a large group of animals, and then we prospectively randomized them to radiographic testing and then to endoscopic leak testing. And then we managed them accordingly.
Right.
And about 15% of the animals had leaks. Now, these leaks were generated by us after we had done a gastrotomy and then had attempted to close it, partially closed it. So we were very suspicious that there was going to be a leak. In any event, about 15% of the animals had a leak, and they were detected by air insufflation and by radiographs, about in equal numbers. And those animals that did have leaks were then underwent closure. And the animals did reasonably well, but of course the ones that did have a leak had more adhesions, they had more infection. So the leaks are very important for us. And the good news is that we were just as good as radiographs, looking at contrast extravasation from the stomach. We were nearly as good as radiographs in detecting leaks I mean, the air pressure insufflation was nearly as good as radiographs.
Right. How do you explain the fact that you did partial closures on these swine and 85% of the time there wasn't a leak?
Well, we were doing balloon dilation of the gastrotomy, and so this is a very common technique in terms of notes when we're trying to dilate an opening into the stomach to get the scope through. And what we want to do is use a balloon dilation many times because it's much easier to close. And of course, what happens is that in a fair number of these animals, they can close kind of spontaneously, sure. And actually just the muscle itself can close enough that there isn't much of a leak after the gastrotomy. So balloon dilation is not a very good way of producing a gaping hole in the stomach.
Right. Do you think in actual practice in humans that making a hole in that manner is sufficient to be able to do the procedure successfully?
So it depends on what procedure. If you're going to do something simple like examine the peritoneal cavity, collect some ascites in somebody with pancreatic cancer, like a laparoscopy, right. All you need is a balloon dilation, put a little tiny scope through there, maybe a 10-millimeter hole, and examine the peritoneal cavity, and then it's pretty easy to get out and close the defect. Versus if you want to do a liver transplant through the gastric opening, you probably want to have a fairly large incision.
Sure. Okay. So where do you go with this data from here?
Well, this is very important data for us, mostly for our animal studies, because we want to try to produce very healthy animals after they undergo NOTES procedures. And right now, to test these animals, rather than subjecting them to radiographs and contrast, we do leak testing immediately after we've closed the gastrotomy to make sure that they don't have a leak and we don't have to monitor them too closely after the procedure. So it mostly has an impact on our animal studies. As you know right now, NOTES procedures in the United States are still in developmental stages. So I think we're not ready for a large clinical launch.
So you're saying don't try this at home?
Yes, I think that's right. This is not something you want to try at home.
Okay.
And I would like to thank the primary fellow, the first author on this manuscript, Dr. Field Willingham, who devoted a tremendous amount of time and effort over a couple of years in producing this major investigation.
Okay. Thank you very much, Dr. Brugge.
Thank you.